Hi guys. This is a lecture we didn't quite have time to get to today, so I thought I'd record it for you so you'd have it ready to study when you study for the test this weekend. So for this lecture, we're going to be talking about the nurse's role in the continuum of care. So what is the continuum of care? The continuum of care is talking about anything that happens health related to the child from the time they're born all the way till the time they die. And so pediatric nursing is just one part of that continuum of care, but it's an important part. And so places, of course, that you can provide pediatric care are home, school, hospital, clinics, rehabs, infusion clinics, cancer clinics, and then also levels of care can be acute, which is generally the ER, or chronic, um, and then end of life. This is from your textbook, figure 1-1, and this basically is a visual representation of what they mean by the continuum of care as far as health promotion. So obviously the family has the most influence on the child's health promotion, and we can just help support that with education. But other influences on health maintenance and health promotion are the community and the culture. So any place in this area that we can contribute to health, we try to do maximize what we can with promoting health. The role of the pediatric nurse is direct bedside care or care at the clinic, um, patient education, patient advocacy, case management, and research. So you can become a case manager, um, and that would mean less of a bedside role and more helping the different healthcare providers remain in a dialogue so that the healthcare is efficient for the child and that they don't fall through cracks. Research that is for more pertaining to nurses that go on to get higher degrees. You can be involved in researching pediatric problems. Societal influences, of course, pediatric patients comprise about 1 out of 5 people in the general population. Um, the There's growing diversity in that population, as you know. We have more and more people with diverse ethnic backgrounds. Family-centered care is a major um, change in the way that we approach care at this point, and it's very important to us as nurses that we provide culturally sensitive care. When you say that children comprise about 1 out of 4 people in the general population, that's not what you see reflected in the hospital population. So you can see by this chart here that the hospital population generally falls in this pink slice here. Most people that are hospitalized are over age 60. Um, and then your pediatric population tends to be well. So you'll see them in the pediatric unit of the hospital, but mostly you'll see a small segment of them there because most of those people, pediatric patients, are actually well patients that never get to the hospital. So, but this is the makeup of the slice of the pediatric population here, the yellow, blue, green, and gray. Cultural influences that are important for us to consider are religion, social beliefs, extended family. They all have influence on the family's health patterns. Communication is a lot of times influenced culturally, ethnically. Health beliefs and how people view the role of healthcare is a lot of times determined by their culture. How the families deal with strangers is different by culture. So, and by that, we're talking about if you're a stranger to that family as a healthcare provider, how open are they to having you give them advice or touch their child, things of that nature. And then the kinds of education or levels of education they have, or their understanding of health can be influenced a lot by culture. Mortality. So when you think of mortality, think of um, death in children. So causes of death in children have a lot to do with lack of access to health care. Kids are at much higher risk if they don't have access to health. Also, a leading cause of death among children is unintentional injuries. So this isn't talking about necessarily abuse in this case, but kids are very vulnerable to having injuries. Also, financial pressures can lead to death in children if parents can't afford the health care. And then the effects of health prevention and treatment can have a lot to do with the mortality rate in children. Technology saves lives, and an example of this is in the past, cystic fibrosis would have killed anybody that had it, usually before the age of 2. When I went to nursing school, usually the death would occur in children with cystic fibrosis by age 10. And by the time I got to my master's program, most of the students or the children that have cystic fibrosis at that point in time were living into their mid-20s. And now I would say that we have some new medications out that could potentially extend lives of kids with cystic fibrosis into their 60s. So that's a great example of how the population then changes that you might see with cystic fibrosis. Also, costs of healthcare is always going up, and there's doesn't seem to be any end in sight to that. And then there's ethical issues that we'll talk about later with mortality in children. Morbidity is not talking about death, but more disease states. So disease or illnesses are in the pediatric population major caused by mood disorders. So suicide attempts is a lot what we talk about here. Pneumonia, asthma, appendicitis, epilepsy, those are all leading causes of morbidity. In this slide, um, this is obviously some older information here, and that's because the textbook is older. I'm hoping to get the textbook updated soon, but you can see that in the age group of or between in the years between 2006 and 2011, we did have a pretty good improvement in the number of kids being born with congenital malformations. And if that's because our healthcare is getting better or education is getting better, I'm not sure. Also, the number of children being born with low birth weight is lower, and the number of children having SIDS has been improving. Maternal complications of pregnancy leading to death in children has stayed about the same. Respiratory distress syndrome and unintentional injuries, there's a gap in the data here. Now, I want you to look at, when you look at these slides, how does this slide matter to you when you're studying? This is going to be how you determine the education needs that the family gets. So you're going to customize your education based on the age group of the child that you are talking to and the family. So based on this slide, that would mean when you're talking about health prevention, and maintenance, you want to prevent unintentional injury would have been, according to this slide, shows that this is your highest priority if you're talking about wellness. So how do you prevent injury? How do you prevent congenital malformations? Well, that would be a prenatal issue, but once they have that, can you deliver any education that pertains to congenital malformations? Well, the education is going to be based on trying to help extend the life. And you can see on based on this one that if you have a congenital malformation and you're a child, the higher death rate is between ages 1 and 4, and a much lower death rate here, 5 to 9. And I would say the assumption there is that if the congenital malformation was not bad enough to kill you by age 4, there's a good chance you're going to survive with that malformation. Neoplasms, so cancer, this is about the same by age group. Diseases of the heart, this isn't talking about a congenital malformation. This is talking about like, you know, atherosclerotic disease and heart attacks. So very low here. You can see unintentional injury is our main source of concern in those age groups. Now, when you're going to a higher age groups, look at this. We have with the age 10 to 14 years old, unintentional injury, so accidents, 4% among this age group, but then it spikes to 20% in the age 15 to 19-year-olds. So when you're giving wellness education to 15 to 19-year-olds, you really need to be focusing in on prevention of unintentional injuries, and that can be car accidents or you know, motorcycle, motocross, skiing, anything like that that could result in death. Then we have malignant neoplasms here, about the same. Homicides, so when you're talking to the age group 15 to 19-year-olds, you can tell that they're at much higher risk of dying by homicide. This is not so much abuse, probably. Statistics, if you review these and kind of figure out what the cause of the homicide is, some of it's gang related and some of it's related to dating partner abuse here. Suicide goes way up in this group, but you need to recognize that 1% of the suicides are in the 10 to 14-year-old group. So even at age 10, we're going to start being on the alert for signs of suicidal ideation. Congenital malformations, again, here the conclusion that you can reach from this is that if you've made it to age 10 to 14, the chances of you dying from that malformation are pretty low at that point. In other words, it wasn't severe enough to kill you, then you're probably going to survive. Diseases of the heart go up in age 15 to 19-year-olds here, and this is mainly among the pediatric population that's obese, maybe has diabetes. Now, here we're going to look at the 5 leading causes of death and injury by age group. And this is 2010, but it hasn't changed that dramatically in the last 10 years. So you can keep this in mind when you're giving your education. So under age 1, suffocation. And this would probably not be included in SIDS deaths, because when we're saying they suffocated, we're saying that it's a known cause of suffocation. So we're talking about things in the crib usually. We're not talking about someone actively suffocating them, although that's possible too. That's the first leading cause of death in under 1-year-olds. The homicide, here specified or unspecified cause. And then 4th here we have motor vehicle accidents. So 4th leading cause of death among kids under 1. Now you go to the age 1 to 4, drowning is number 1. So you see how this can affect the teaching you're going to be giving these different age groups. And then motor vehicle accidents go up in this age group, and that, you know, that could be improper car seat installation. I would think, or parents failing to secure the child. But I think most parents use car seats at this point. Most of the deaths are related to it being improperly installed. Fire and burns is on this list now as a fourth cause. Age 5 to 9 year olds and up, it's now number one cause is motor vehicle accident, motor vehicle accident, motor vehicle accident. So high cause of death. Age 10 to 14, look at suicide is up there, even higher than 15 to 19-year-old. So this is a pretty shocking statistic here. And then homicide. Look, it's number 2 for 15 to 19 and number 2 for the underage one. That's because in the underage one, they're more likely to be harmed by a parent. And in the 15 to 19-year-old, it says here firearms, so they're more likely to be shot in gang violence or perhaps dating related or partner related. Then suicide down here by firearms is 5th on the list. Poisoning's on here. So high number of kids 15 to 19 dying of poisoning. And I imagine that's because you could put this in here with suicide probably. But it would take a little bit more digging to tease that out. Informed consent is a major concern with pediatric populations. So informed consent is, of course, the authorization that you would get from the parent that the child can be treated. And generally you need this before any invasive procedure can be performed or the child can participate in research. This is obviously an old picture. You can tell by this computer screen, but this is an example that's in your book because this child became well known for going to court because he disagreed with his parents. He had cancer and he wanted to have the permission from the court to be taken off treatment, and his parents disagreed, and usually we listen to the parent over the child. The parent usually has the final say. However, this court case involving this child changed all that because the court looked at it as though he had the right to make that decision because he was 15, and he didn't want to divorce his parents, which is basically a divorce process you go through to get there's a word for it that's escaping me at the moment, but basically to be emancipated, an emancipated minor. So he didn't want to do that because he felt that would be hard for his parents, and that would have been a different legal place that he would have been in. He just merely wanted the right to refuse any more treatment for his cancer, and he ended up winning that court case. So because of that case, we have a mature minor doctrine, and we'll talk more about that in a minute. But this brings up ethical decisions. Most of our ethical problems with pediatric patients come about because the child wants to be a DNR and the family doesn't agree. It can also come up if there's money involved. Sometimes kids, if their parents are died, they have a trust, and the trust usually is whoever's taking care of them at that point only has access to the money while they're under 18, and so there's a conflict of interest sometimes that arises, and that was a case with Anna Nicole Smith and her child. So consent requirements now, like I said, the child can become an emancipated minor, and then they're allowed to make their own healthcare decisions, or if they reach 18 years or older, or because of that court case that I brought up, you can now be considered a mature minor at a younger age based on the developmental understanding of the child about what the ramifications of their decision is going to be. So in other words, they have to be considered mature enough to understand death and to understand the permanent nature of refusing treatment or getting a treatment. That sometimes we have cases where children come into the hospital before the parent can be there, and there's no clear person that we can get consent from. So in that case, if the child is, um, you know, it depends, the exact age varies, but like let's suppose you have a child that's 12, 13, and the doctor explains what's happening to the child, and they agree to a treatment. That's called voluntary. And they would do that anyway. So even if a parent agrees to a procedure, generally they'll try to get voluntary consent from the child too. And that's important because more and more we're trying to have children feel that they're in control of their health. Kids are still, they still have a right to be informed of the risks. It used to be something we would never worry about talking to a child about, risks and benefits of procedures, but they have a right to know that if they're old enough to understand. And then there was a law that was passed called the Patient Self-Determination Act, which basically put all these kind of considerations into law. So it's considered now that patients, children, even though that they may not have the to actually consent for a procedure, they still have the right to be educated about it and to give verbal assent. And this is the mature minor doctrine that I was talking about as a result of that court case that happened. It says, the mature minor doctrine is a common law rule that allows an adolescent who is mature to give consent to medical care. Ethical considerations and decisions regarding consent and confidentiality should be distinguished from legal requirements. So the court basically sided with the child in that case, and here it sets the age as 14, where a child could potentially understand well enough to make a decision on their own about the risks and benefits of something, and they consider that they're able to make what's called an adult-like decision, as long as they're able to demonstrate signs of maturity, mental maturity. So that's kind of a good thing for us in the hospital setting because it takes away some of those legal problems. Sometimes, though, we do have to get a court order. Cases where that might happen are like, let's suppose we have a child that needs blood products and the family is Jehovah's Witness or something. We have to, at that point, get a court order, and there's usually a judge available 24/7 with a beeper to be able to handle those kind of problems, so it's not like a long drawn out court process. And then also, if the doctor is acting in the good faith best interest of the child, that's often considered good enough when there's no parent around to give consent. Some key considerations: the parent's choice should not be in conflict with their interests. So I brought up the case of Anna Nicole Smith, where she died. She left a substantial amount of money to the child in trust. The child was, I believe, a toddler at the time that happened, and so the child's father took over care. And that child's father, they had been estranged for a long time, and so as long as he was caring for that child, he got a bit of money associated with taking care of that child, that would have been cut off if anything happened to the child. Let's say, for example, if the child dies. So, in that, let's suppose that child were to have a situation where they were brain dead and should be taken off life support. That parent would be considered in conflict of interest because they have a financial benefit of keeping the child alive. As far as their source of income. So that is important to think about sometimes. Also, we think about if the parent is making a choice for their child that is not life-threatening. So for example, if a parent refuses a vaccine, we don't just go in and get a court order to override their decision because it's not life or death. With blood products, say we would, because that would be potentially life-saving, and not getting the blood would be life-threatening. So that is something that's important in the decision making. Other ethical, so besides withholding or withdrawing treatment, other ethical issues can be genetic testing. Sometimes we really need to do genetic testing on children to see what their risk is of certain genetic disorders. Sometimes that the parent may not agree to that. For example, let's suppose you have a child where the father doesn't know that he's not the father. This can sometimes be an ethical problem, or this more commonly maybe would be something where they don't want the child to know they have a terminal disease. For example, there's a couple of terminal diseases out there that are so terrible that a lot of parents would say that they'd just rather not know if the child has it or not. And other ethical issues concern organ transplantation. So when kids are brain dead and they decide to do an organ transplantation in order to give those organs to someone else, that can raise a lot of ethical concerns. So just keep those in mind. So medication errors is a big deal with pediatrics, and mostly that is because, with adults, if you have 5 adults and they're all different ages and weights, let's say they're on a medication. Most of them are going to be on the same dose because it's a average dose for people. Pediatrics, as you probably already know, the medications are by weight, and the weight can change every week. And so there's a high level of medication errors in the pediatric population as a result of those kind of things. And also, if you're used to giving a standard dose all the time, you're more likely to catch the error. If you have no standard dose because everything's weight-based, you might not catch an error in the dose. And so that's why it's important when you work on a pediatric unit that every single time that you give a medication on the peds unit, you have to not only look up the dose in the book. Don't take the word for it that what's written in the order. You have to independently verify the dose with a textbook or a scholarly source, and then you have to verify the weight and the calculation. You can't just go by what's on the MAR. And then also you have to be sure that you know what the med's for, because giving the wrong med is much more deadly in the pediatric population than it is for adults. Every time you give an IV rate, the same thing, you have to verify that that IV rate is safe. You should already know from the MAPE about whole numbers and all that, but just to focus on some of the biggest ones. So in summary, the nurse's role extends beyond bedside care. and it goes much deeper than that out into the population. The pediatric population is more and more diverse, so we have more and more issues with language barriers, for example. So make sure that you always follow hospital policies regarding getting interpretation. Make sure that you always keep up with continuing education about culturally sensitive care, and be aware of the legal and ethical issues on a specific pediatric unit. All right, thank you. There's one more lecture that I'll be posting, so make sure you watch both of them.